I'm Will King. I'm a clinical scientist at St George's Hospital in the South West Thames Genetics Laboratory, working there for about 16 years. And I now do more of a management role, but I did do a lot of the lab work and reporting originally. I actually did meet Ed Southern, who's the inventor of the Southern blot. He actually invented it in the mid to late 70s, and it was immediately used by a lot of diagnostic services that were set up in the 80s, not just for Fragile X and myotonic dystrophy, but for other conditions as well. And I was training in the late 90s, and it coincided with Professor Southern's visit to our genetics centre to give a lecture. And he gave a lecture at lunchtime, and it was on the same day that I was actually setting up a blot in the lab as a trainee. So I had to rush out of the lecture at the end to go and stack my blot up, put the tissues on the membrane, get everything ready. And I just put the weight on top, and our head of lab came round giving Professor Southern a tour. And he walked past my blot and glanced down and said, "Oh, you still use that, do you?" Southern blotting is quite a laborious process. It does take about 4 to 5 days, if not longer, to get anywhere near getting a result. So what you would have seen previously is how we set up a Southern blot. So we digest the DNA with enzymes, we run it through an agarose gel. The gel is then positioned on top of a certain platform with a buffer, which enables the buffer to transfer through the gel, which pulls the DNA with it onto a membrane. That takes a good few hours. And then eventually you end up with most of the DNA transferred to the membrane, we hope. It's then stabilized or fixed to the membrane by baking the membrane at about 80 degrees for a couple of hours, after which we then hybridize it with a probe, which is a small fragment of DNA which contains a known sequence, and that's the sequence that we're looking for when we actually then come to develop the blot, which used to be done by autoradiography or X-ray film, but nowadays more commonly done by fluorescence. Nowadays, we use Southern blotting occasionally. Our lab is one of the few left in the UK which is doing it, and we are doing it an awful lot less than we were before. So back in the, say, early 2000s, late 90s, we were doing 2, possibly 3, sometimes a week for Fragile X and myotonic dystrophy normally. Nowadays, it's been superseded by PCR-based techniques. But PCR is still a bit limited, so we can detect the presence of large expansions in Fragile X and myotonic dystrophy, but we can't tell what size they are. So occasionally, mainly now for myotonic dystrophy prenatals, we are asked to run blots. Myotonic dystrophy is a bit of a tricky one, because what the Southern blot allows us to do is it allows us to get a size of the expansion. So in Fragile X, we can use the PCR technique to say that there is an expansion there, and clinically that's what they need to know. The size of the expansion is kind of not as relevant clinically. They've just got an expansion, therefore that confirms the diagnosis of Fragile X. But with myotonic dystrophy, it exhibits a phenomenon called anticipation, which is where in each successive generation, if the expansion increases in size, the severity of the phenotype changes and gets more severe, and also the onset of the disease is sooner in life. And what we're most interested in is being able to pick up congenital myotonic dystrophy, which is where an expansion can be passed from the mother to a child, and in that process the expansion becomes very large. And it means that if this isn't picked up before the child is born, when the child is born, they can have a really severe form of myotonic dystrophy, which can mean they may have to go immediately onto a ventilator, they may not be able to feed properly, and in quite a few cases, unfortunately, is fatal within the first few weeks of life. So it's a very unpleasant position to be in if you can't get that size. So the PCR technique will only tell us that there is an expansion, it won't tell us the size. There are some pros and cons with Southern blotting versus PCR. The first thing is that Southern blots require quite a lot of DNA to actually be able to eventually visualize anything from the blot. So the DNA that we use on the digest that's run through the gel comes directly from, say, a blood sample where the DNA has been extracted from. Blood samples normally have enough DNA that we can get to be able to do a southern blot. Usually that's just from adults and children, but from small babies and from prenatal samples you often get a lot less material to get DNA out of, and therefore we have to be a little bit selective about how much we run on the blot, because often there isn't enough to do everything we need, and sometimes even then the result can be very faint, so that is a little bit risky. On the flip side, southern blots do have a slight advantage over PCR in that they're not as sensitive to maternal cell contamination in prenatal samples. So prenatal samples are obviously taken invasively, and there is a risk that there can be some maternal blood or some maternal tissue picked up at the same time. Southern blots aren't sensitive to that in such a way that PCR is, so it's not so much of a risk that what you're seeing on the blot is actually the mother as opposed to the unborn child. With PCR, even a small amount of the mother's DNA, we estimate anything less than, well, around 10%, can actually cause the PCR to preferentially amplify that allele from the mother as well as the prenatal sample. So if there is maternal cell contamination, we can't always tell for definite whether what we're seeing is the mother or the fetus. We can do additional tests that will discount the fact there's maternal cell contamination, so we have to do a little bit of extra work. But with blots, that isn't so much of a problem. And finally, obviously I have mentioned already, is the cost issue. The blots use a lot of specialised reagents and equipment. That's an initial outlay. The reagents they use on a regular basis aren't too bad, but they can be a bit pricey, but a lot of the time it's the labour. It does take a good 4 to 5 days of a technician's work to get this through. PCR, on the other hand, even if it's a commercial kit, is much quicker. You can often get a result in a couple of days. I mean, a PCR itself will often only take a few hours to run, then it might have to be run on an analyzer just for a few hours or overnight. You can have a result quite quickly. So to summarise, basically southern blotting has been used for many years in labs, but has mostly been superseded by PCR-based techniques, apart from conditions like myotonic dystrophy where we do want to know the size of the expansion.